hopefully in this video roundtable discussion, we can share some real practical insights into what you can do to deal with the patient matching and overlay problems, and that, honestly is in every healthcare organization. We have two special guests. First, I want to introduce Beth Just. She's CEO and president of Just Associates. Welcome, Beth.
Thank you. It is a pleasure and an honor to be here today with you, John. And I'm looking forward to the next 45 minutes.
Great. So, Beth and I have done this before, and she has such great insights. But for those that don't know you, Beth, give them a short background on yourself and a little bit about Just Associates.
Sure. I come from a health information management background and have worked in software, electronic health record companies for a number of years, and 16 years ago started my own company focused on patient data integrity. I also have served on the AHIMA board of directors and currently serve on the College of St. Scholastica's board of trustees. And so it's been a fulfilling and pleasurable career I've had.
Nice. Well, in the lead up to this, we tweeted out about the video roundtable, and someone replied, these are some real experts on the call. So that's a credit to you and to Grant. So our other guest is Grant Landsbach. He's system manager for data governance and interoperability at SCL Health. Welcome, Grant.
Hi. Yeah, thank you. Very glad to be here.
Yeah. So Grant, for those that don't know you, want to share a little bit about yourself?
Yeah. So I've been doing this for about 13 years now. I've been in healthcare. And I also am pretty involved in AHIMA, the American Health Information Management Association, and their state chapter, which is our Colorado version. Our headquarters for SCL Health is in Denver, Colorado. So I've been CHIMA president. I've been on some of the AHIMA practice councils. I've done some stuff with CHIMs. So I'm pretty involved in a lot of the professional organizations as well.
Awesome. Well, we're going to have a great discussion here, and thanks for everyone that's watching live. If you are watching live and you have any questions, be sure to share them on Twitter. The easiest one is @TechGuy. You can share it, and we'll try to incorporate it either during the discussion or at the end. Also, if you're watching on the Healthcare Scene page, there's a link where you could add questions in the YouTube chat as well. So feel free to send those questions over. If we can't answer them now, we'll reach out to you after or connect with you afterward and send answers to those questions. So let's kick it off. Maybe Beth, you want to start us off? What is an overlay for some of those that are watching that may not know what an overlay is, and why is it considered among healthcare's most dangerous, misidentification problems, which is the core of your business, is solving that misidentification problem? But what is an overlay, and why is it a problem?
Sure. An overlay is created when two different patients' information gets commingled within one medical records. It most often happens at the registration event when an incorrect patient record is selected by the registrar, and core demographic information ends up getting changed and a new visit is added to the wrong patient's record. And obviously that leads to commingled demographic and clinical information, and that obviously can create unsafe medical decisions and unnecessary exposure to duplicate diagnostic tests and even treatment. And so it's a very, very dangerous patient safety issue. From a financial standpoint, overlays are incredibly expensive, and I know Grant can attest to this through his research study that he did and his business of managing the data. And they're really difficult to identify unless you monitor heavily every demographic change that happens. They're very, very time consuming and costly to monitor and correct. One study puts a starting cost at $50 a record. I think that's probably very understated. And certainly the longer that they exist, the harder and more expensive they are to get rid of. And the overlays their danger has intensified over the last several years as more and more organizations have moved onto an electronic health record platform, and that not only infects that particular system, but a lot of internal downstream systems and external systems with that erroneous data.
Yeah, that's a great insight. I mean, as we add more systems, the overlay problem just seems to go exponentially worse. I think it's every HIM professional's nightmare, right? I mean, CIOs and CEOs as well. So, Grant, she mentioned the study you did. You did a study on overlays in 8 hospital, multi-state healthcare systems. So, a pretty good, size health system. How prevalent were the errors that you found in the health system, and where did you find those errors happen most often?
Mm-hmm. So in the study, we did I used admissions as my denominator. That seemed to be the best. So this is over our entire system. So it was over a number of years. I think it was since 11 through 15. So 5 years worth of data. So the admissions during that time for the entire organization was 5,957,375 admissions, and there were 555 overlays. So if you look at that, and this is sometimes what you battle a little bit in the C-suite, is if you look at that, yes, that is a lot less than even 1% of the admissions, but that still comes out during that same period of time to be 9.25 a month of these. And each one of these poses a pretty significant risk to the patient and possibly to the organization for legal issues and things like that. So, it is one of those things where you might look at that and you might get some of that. Sometimes you hear that, you'll hear, well, that's so small, that seems insignificant or something like that. And you're like, yeah, but the potential that could happen from one, you wouldn't say that about, a botched surgery that, 9.25 of those are okay per month, and I think that, and it really is on that same level, because if you get the patient wrong from the beginning, then everything goes wrong from there. And when I was doing my literature review for this, I found a lot of studies about medications being given to the wrong people and stuff like that. But a lot of them didn't end up tracing it all the way back to say, a portion of those or a large percentage of those is because from the very beginning that patient got registered, they got them on the wrong patient. So it's a big deal. What we found is that user error. Sometimes these can happen because of fraud. That does happen. People come in, they lie about who they are. Depending on your policy, most people go ahead and take people's word for that, especially through the ER. They don't make them prove who they are necessarily to put them in the system. So that is typically the situation. So we looked at that just to see, but there's only 2.5% of those 555 had to do with fraudulent activity. So the rest fall into a category of being user error. So 97.5% turn out to be mostly user error. So we'll keep that in mind as we talk about more of this. The number one area they were found in was definitely the emergency room. So this is mostly acute care, although for this study, it does include our clinics. We have 250 some clinics that register patients too. So it does include them as well. So even with all their data in there concerning overlays, the ER is by far. So 62% of them came through the ER, 12% through main hospital registration and scheduling, 10% through the lab, which is interesting because labs do a lot of that outside type reference lab work. And those people aren't always trained to search and select patients properly. I think that's what's going on there. A little bit of that with radiology. And then you get into some of the smaller areas, labor and delivery and oncology and just general stuff like that. But emergency, main registration, and then lab are kind of the 3 biggest areas.
That's great. Hey, one other question. So how did how were these overlays typically identified? What was the process you went through to kind of discover them? Because I think everyone agrees we don't want overlays, right? But then how do you identify them?
Right. And so just to frame that a little bit, the way I did this study is we had an access database. We kept all these points of data in for every single overlay because they're such a big deal. So I had really amazing data to do this study with. So when I looked at that, that was one of the things that we looked at. And we did find out that typically the way they were found is through actually 54% were found by registration themselves, or people that we would call registration. So what happens there is they make the error and then they realize sometimes quickly after, sometimes not so quickly after, oh shoot, that was the wrong person. uh-oh, and then they tell us about it. You know, we, in my team's data integrity, we clean all these up. So so they're still, the majority of them were still being found and are still being found by our registration team. But right behind that, 31% of them were found on what's called the identity change report in our particular electronic health record system. And that report is something that we look at to look for demographic changes, serious demographic changes that happen. So date of birth gets changed, or somebody's name completely changed, or sex, or something like that. It shows up on this report that we monitor every single day. So we did find 31% of them that way. So doing those proactive surveillance type activities does net you a lot of these. And then again, registration finds their own. We had clinical informatics find some, billing find some, because when they bill, sometimes someone will call and say, I was never at your facility. That's that's a good indication that you have an overlay. So, you know, there was some of that too, but by far registration and us finding them on the proactive reports that are out there with our EHR.
Well, that's great that the EHR is providing those tools and helping you identify them. But, you know, Beth, you know, it seems like technology is a double-edged sword, right? It can help, but it can also make things worse. Have you had any experiences in that regard?
Yes, you know, technology, you know, as great as it is for facilitating a lot of improvements in, you know, communication and clinical care, it can also exacerbate the overlay problem in several ways. So one is, you know, when two patient records are auto-linked using the EHR's matching algorithms, when those thresholds for auto linking or auto merging are set too low, you end up with like twins getting auto merged, or people with, you know, very common names that happen to have the same birth date. Those types of things, if you're not real careful, you can automatically link or merge records that belong to two different people. Another item is the auto merging using third-party data sources. So there's a lot of third-party data sources out there that contract with healthcare entities, and you know, they say, hey, we have the magic button. You know, you just use ours and you don't need humans to be looking at the data and doing those merges manually. And through our use of that, we have found that there's a pretty significant error rate in those third-party data sources. So if you rely on it without any human quality checks, you're going to overlay records. I'm a great example. I use one of the credit monitoring agencies for my identity fraud and theft surveillance. And they have my daughter's record mixed up in mine because her first name is Elizabeth. They also have one of my mom's previous addresses on my record. Her name was also Elizabeth. So I'm a great example of how third-party data is not the be-all to end-all to the accuracy of its information. And if you rely exclusively on that, you're going to overlay records, no doubt.
That's interesting to think about how technology can help but also hurt. And in some ways, you know, I mean, it was interesting to hear Grant talk about this report that he receives that then incorporates a human, right? So the technology creates the report, but then the human evaluates it. And I imagine, do you get into alert fatigue, you know, when as you get these reports and there's no overlays, like, then you're like, okay, I need to stop. Did you run into that, Grant? Or how have you thought about that? Because obviously it's a big problem in the EHR system for doctors. Hadn't ever thought about it from a overlay perspective. What do you think?
Yeah, a little bit. I mean, you know, they do have to be trained, because sometimes, you know, something like a woman's name changing, last name changing due to divorce or marriage or whatever is pretty common. And those will show up on a report like what I'm talking about, because that does qualify as a significant demographic change. But they're also getting smarter. You know, I mean, if there's anything else in there where she has that name in an alias field, then it won't, you know, we can program it not to show up on that list. So there is some of that with some of those, they do have to go through. And usually for us, you know, we're going to look for an ID, a license, or an insurance card to validate that they did have their name changed or whatever. in that regard. And you can hone some of the algorithms a little bit better. That's kind of that piece of using technology where you can actually make them a little bit better, so you're not totally going on alert fatigue like you talked about, so that you're not looking at necessarily every single demographic change, but just ones that you would deem, major, so that you're not having to look at every single one. So there is a way to kind of do that. And over the years, we've been able to do that.
That's great. I mean, it's always a balance, right? Because if you go too far, then you miss ones that you should have caught. So it's an interesting balance. Let's go back to some of what Grant was talking about, as far as, how do you justify, the cost associated with an overlay. As he said, 555 over 5 million, admissions, it seems so small. If I'm a hospital executive, Grant talked about a few things I think that are interesting. And, if we said, hey, if we could have five patient safety issues a month, they would freak out, right? That would not be okay. It would not be acceptable. So why is it acceptable with facial matching? But Beth, any other insights? Because there's not really any great studies out there, on the industry average of what it costs. I mean, you mentioned the $50. So let's talk about that. What's the full financial impact and patient safety impact of having an overlay? Beth, you want to start?
Sure. Grant mentioned one initially, which is obviously the most significant, and that is if something goes wrong because you had an overlaid record and your organization gets sued, that's going to be very, very costly, obviously. But there's just daily costs that end up occurring when you have an overlaid record. And some of it are, related to, denials or delayed claims. So just, strict loss of revenue. There's also the human resource aspect of having to correct those. There's been, studies that show that, it could take 60 to 100 hours to reconcile an overlay. There was an article that was published a few years ago that it took 16 staff members over 3 months to correct one overlaid record. It was a pediatric facility. And it ultimately cost that organization nearly $43,000 in lost revenue, because by the time they got the record fixed with this multidisciplinary team, by then the 3 months, the 3 months had elapsed and they couldn't file the claim. So they lost $43,000 in revenue.
Wow.
There was another study at another pediatric facility that said, patient records that are associated with, misidentification issues result in repeated tests and treatment delays. And, 10 years ago, that organization averaged over $1,100. So now we estimate that that's way higher than $1,100 because that study was done so many years ago.
Now that's some great insight. And you didn't even highlight my favorite one, which is showing up on the 5 o'clock news because the information was wrong in an overlay. I mean, that's scary stuff. And ask anyone that's been through a breach and they can tell you that experience is awful. Anything you'd add to that, Grant, as far as, making the case to your executives that overlays, matter and need some investment of time and money?
Yeah, well, Beth is absolutely right. And I think maybe one of the reasons that there isn't a great study on this, because I did my study, which is pretty good, but I didn't put numbers to it because it got really difficult because overlays are a unique scenario by scenario situation. I mean, if you have somebody that gets overlaid and they don't happen to have much of a history at your hospital, or they were only in for a few hours in the ER or something like that, that's an easier cleanup than somebody that goes through the ER, gets admitted for a week. I mean, we've had a couple of those, and those can take, months, literally months to clean up. And on average, there's usually some kind of an ancillary system involved. So, they did labs, they did radiology, something like that. So you're having to go out and facilitate this cleanup with those other teams. And we haven't even got into what happens with all the triggers we have these days that sends information all these other places, like to exchanges and RHIAs and insurance companies and down the line. Once those things happen, once like discharge happens, those things fire off, or even before discharge, and now you have to contact all those people and tell them, hey, by the way, all that information you got, yeah, belongs to the wrong patient, you know, that kind of thing. So the amount of people that have to get involved in these, especially, it just seems almost more and more adds to that cost. And that's why it's difficult to calculate. So that's probably in part why there aren't any great, you know, huge landmark studies on this. But that's the truth, is that they can take months and months. And I know early on, we haven't had this happen in a while, but early on we definitely had some where we lost reimbursement because we couldn't get them cleaned up in time to get them coded and rebuild. So that was, you know, I mean, and they were big numbers. I mean, we lost some serious reimbursement.
There's very few hospital visits that aren't big numbers, right?
Yeah.
Especially if you have an overlay problem. That probably means they've been there before, which means they're a chronic patient, which probably means that, you know, you're going to be paying quite a bit of money for their visit. And there's exceptions, of course, but maybe that's the problem, right? You know, there's such a wide variety of overlays that it's hard to put a number on it. But I think you guys gave some good perspective on what the costs are. So thanks for sharing that. Let's move to kind of the correction plan. You know, Grant, what's your approach, you know, to a correction plan for this, and you know, in eliminating the overlays? You know, what does it entail? And maybe then, you know, after that we could talk about, you know, who do you need to involve to make this happen? So, you know, what's your correction plan approach for overlays?
So we have a correction plan that has evolved over the years, but it's up to about 70 different unique steps of different things that need to be checked. Yeah, so it's, you know, pieces that need to be checked, things that need to be done. If it has lab, you have to do this. If it has radiology, you have to do this. You have to take it off the patient portal so that they can't go in and see it. You have to put a flag on it to make sure everybody knows not to readmit on that account. You know, I mean, it gets deep. And what we've learned, you know, by doing this is there are tools, the EHRs that are getting a little more sophisticated, knowing that these happen, knowing that this is a problem. So they've given us some tools to do things like move notes electronically and stuff that are a little better than what we used to have maybe 5, 6, 7 years ago. But it isn't, none of those things are a panacea, like just undo the overlay. There is no undo eraser button like that. Like, you still have to go to all the different ancillaries. You have to get registration involved to create a new medical record number sometimes, or at least a new visit where you're going to be moving everything off the bad one onto the now good one. That they have to get involved in every single one. To do that, every ancillary that's involved has to get involved. Sometimes clinicians, if it's a, you know, there are things, I mean, that is best practice, is to try and get clinicians to re-sign documentation in the new chart. It gets like very sticky like that. We get clinical informatics involved to help us with that piece. So it's pretty amazing like that. But yeah, the list is about 70 check marks long to try and make sure that we've covered everything in this, you know, as we undo one of these. Mm-hmm.
So in that checklist, do you include the patient? You know, what's the requirement for disclosure there? I'm not familiar with that. You know, maybe other people are, but do you have to involve the patient and let them know what happened?
Well, you certainly do if something's been disclosed. So even a bill, if
Sure.
a bill went out to the wrong person, then yeah, you have to get the patient involved. There has to be someone contacting them. We have patient representatives, or compliance will do that.
Right.
If we have to. If it's all internal and we catch it and it's all isolated to that one visit and there wasn't any, you know, clinical decisions that were made because of this that would have impacted them or anything like that, then no, we just need to make it so that it doesn't go any further. So we have to put the FYI flags on it, make sure no one admits to it while we're cleaning it up. It's sort of like a work zone, you know, it's got tape around it. No one can use it. So if that is a chronic patient, like you were talking about, and they come back in and this thing's going to take us a couple weeks to clean up, that has been, and that happens. And that is a problem, because then they come back in and we have to admit them on a new MRN. We can't put them back on that medical record number, which means the clinicians can't really look back and see all their history and everything, because it's under construction. We're fixing it. We're working on it. So that is a problem, and we have that occur. So yeah, it has. And then at that point, you know, we would tell the patient. It just depends, you know. So you do have to, if there was anything that got released, or if it's impacting their care in any way, then you do. Once in a while, you get one where it really doesn't. It's just historic visits that need moved or something like that. Then you don't have to disclose on that. But compliance has to be involved in every single one. We do an occurrence report on every single one, and compliance makes that decision. of when to contact. Mm-hmm.
No, that makes sense. And, what an interesting challenge that you create an overlay over your overlay when they come back again, right? Essentially. Beth, anything you'd add to that? Or, let's also talk about the governance of who should be involved in fixing the overlay. We talked some, but Beth, any other comments?
Well, I think, the program that Grant and his team have created is really, really a very thorough, very sophisticated program from a process standpoint. And, I think some of the things that Grant has talked about just highlights the need for catching these as soon as possible, because the sooner you catch them, the easier they are to fix. It's when the patient's been here a long time, or we've seen overlays that have been buried in the system for years. And then to try to peel that apart is an absolute nightmare. So I think, certainly having a multidisciplinary committee that kind of oversees this process is critical, which, Grant has got. And because oftentimes it takes the doctors, the nurses, the therapists, everybody to get involved to figure out which order belongs to which patient, and was this result on patient A or patient B, et cetera.
That's great. Who else should be involved, and who really should take the lead, Grant? I call it truth in job description. If it's not in their job description, no one takes ownership, or it often is the case. What's your experience, Grant?
Yeah, well, so before I answer that real quick, one thing Beth said that I do think is important to note is, in the electronic health records these days, in these systems, they have we call it patient level type stuff. So medications and allergies and things like that, they live up at the top at what we call the patient level. So they apply to every visit that happens. And so unraveling that stuff, you can imagine, is a little harder too, because you could say, well, this order obviously goes just with this visit, or this, discharge summary goes with this visit. But when you look at some of those things like medications and allergies and stuff like that, it's not that easy to just look at it and say, oh yeah, this allergy belonged to this, patient A, and this one to patient B. And that's where you almost need a clinician to step in there and take a look at all that and help you, because we're not clinicians, so we do have to have that. That was a good point. But no,
or you go to the audit logs, I guess. Do you look in the audit logs and see, okay, that was entered on this date and this patient came on this date? Is that?
Yep, that's kind of how we end up trying to figure that out, of like at what point was it, or updated or whatever, and try and figure that out. And sometimes, the answer is just to wipe some of that information, so that on both of them, so that the next time they come in, it's just recaptured, so that you're not, it's better than risking having the wrong thing on the wrong person. So sometimes that happens too. But yeah, we are the ones, so data integrity, so we're under health information management, and our department is under IT. That's not always the case. Sometimes HIM's under revenue cycle, and that's fine too. But you need someone to be what we call it, the facilitator, right? I mean, somebody has to be looking out for the legal health record and making sure that after one of these happens, that all the documentation ends up in the two, separated and where it needs to be, and without this person's name on this person's and that person's name on their record, and getting all that sorted out. So I think somebody in HIM or some group in HIM is a natural fit. And a lot of times these days, there is a data integrity team or a manager or somebody over that, it makes sense for them to have, and compliance always has a piece of these too, but the actual cleanup and making sure that the legal health record is okay, and working with the ancillaries and all those different parties, it makes sense to be whoever's the custodian of the legal health record, which is still somebody in the HIM world.
Yeah. I think you may have just made a number of our viewers jealous. They said, I wish we had a patient integrity team, because I think a lot of them are doing double and triple work, which maybe is part of the problem with overlays, is that, they're doing overlays and they're doing ROIs and they're doing billing, and, in different organizations. So, it's a challenging thing for HIM professionals. And I always say that HIM professionals are not given the credit they deserve for the hard work they do. So let's shift to okay, it's great that you corrected it, right? But to Beth's point, it's much better to get there early, or even to eradicate the overlay from happening in the first place. So how can we do this to prevent new ones? Grant, you want to talk about that?
Yeah, I mean, so the first thing I would say is to create an iterative cycle. I'm going to call it an iterative cycle. So that's meaning that you're capturing all these errors and you're feeding those back to the front end that, is creating them and showing them, look, these are happening and we need to kind of look at this. Now, I think just starting that process is what's important, and being diplomatic about it is important, because it's easy to say, oh, you're making all these errors, you guys are screwing everything up, right? And that is not true. My folks, they get to sit with a registration person in the ER and general registration for a day. And after that, all those perceptions change, because it's like, wow, these people that come, patients are sick and they're not happy, and these people have to deal with a lot, registration does. So there are reasons that these errors get made, especially in the ER, in such an intense environment like that. And so, but creating that relationship with your registration front end managers and stuff like that, so that you can feed them this data back and then they can go talk to their folks about it. And what we've had here is they've even changed some of the policies to where with overlays, somebody might get education the first time that it happens, that kind of thing. But if it's egregious enough, I mean, if they're making that error enough, then they do get some kind of formal, reprimand and get in trouble for that. But they don't get in trouble for creating duplicates. And we realized that early on, that you can't really slap hands for both of those things. I mean, if you're going to say, overlays are the big problem and we want to avoid those, then you kind of have to let them create duplicates. And in our EHR, they can create a duplicate and then they can do what's called marking it for merge, which is to tell my team, it's another report we work, hey, I created the second Mike Smith because I couldn't tell that the one that's in the system really was him. So I created a new one, but you guys go look at it and check it out and figure out if that's really the same guy. And so things like that kind of, and training can't be overstated, obviously. I mean, we've become a lot better about that here. They have to have yearly training now through online modules where they have to go over, the best ways to search and select patients, not to mention their scripting of what they should be asking to get enough demographic information to really make a positive match. So we're trying to do a lot better with that. It's a little more challenging at the clinics, and the turnover rate for some of these front end folks can be high, which is something I've always advocated. Like, I'd like to try that someday, like pay the best in town, but, really hold them to the quality standards for that, and see if you can retain the best people, the people that are best at this kind of thing and really detail oriented, and see if it would pay off on the back end. I think it would.
Is that your next study? Your next study is to look at having the best people there to avoid the overlays. That would be pretty interesting.
Yeah. So those are just a few ideas. Yeah, I think that, having good surveillance and all that is really important, so that you're finding these and then obviously capturing the data on these errors. And that is a part that can be difficult, because EHRs don't always do that well. They don't have reports that say, oh, you had this many duplicates or you had this many overlays. They don't always do that well. So sometimes you have to keep it in a third system and you have to ask your folks to keep track of those things. But I think that it pays off. I really do, as long as you're keeping it to a certain degree. I mean, there's some level of detail that might not be worth it, but if you have general numbers, and we can break it down by what areas they're coming from, and also we can tell a manager, your employees, your five employees, this is how many overlays they had, this is how many duplicates they had, that kind of baseball like statistics, and it makes a big difference to feed that back to the front end.
That's great. No, I think you gave some really good practical insights around the relationship. I mean, I think that's key to, preventing them in the future. I love that you have them sit in with the registration desk to give them that perspective, such forward thinking ideas. And then of course, being able to communicate back to them, making sure they're trained is a huge deal as well. Anything else you'd add, Beth, as far as prevention of these overlays?
I think Grant really zeroed in on the most critical, and that's training and that feedback to them. I work with lots of different organizations across the country, and while I'm seeing a lot more organizations do have a data integrity team, there's still a lot that don't. And even some that have it are not as diligent as Grant about collecting that data and really analyzing it. I mean, turning that data into actionable information that can be used by the patient access management team and actually help to, improve the process overall.
Mm-hmm. Yeah, the only other things I might add too is, I think that there are things, and I don't know, Beth, maybe you've seen some of this too, but every version of REHR upgrade that comes out, they have new things too that you can add on the front end screen. So we have an auto duplicate checker, for example. So if there's two Mike Smiths that are similar in the system to what they put in, it's gonna spit up like a pop up to them saying, oh, well, hold on a second, are you sure it's not this guy or that guy? I mean, I think those are worth pursuing. I think you can overdo them, and I think it can become pop-up fatigue, and then they just go right past them. But there are some things too to try and help with that. Photo ID is one thing that's helping. Capturing, IDs or capturing the person's picture in the ER is a new thing that's coming. A lot of people are doing those kind of things, different biometrics like that. I mean, things like that on the verge are going to help a lot. And the other thing I'd say is if you're having trouble with raising the profile of this issue to the C-suite or anybody, I would say get your compliance and legal involved, because they're going to be your partner in this. Because once they understand it really well, then they're going to be your best friend as far as trying to raise this, up the ladder.
Right.
That's great.
Right. And I think one of the things that Grant just mentioned and is, for the general audience is that, he's fortunate that the EHR system they use has some pretty decent tools built into it. Nobody else does. None of the other vendors do. So, a lot of the things that Grant is able to do, a lot of organizations simply can't do because they don't have those tools in their toolbox within their EHR system.
That's a great lead into questions. And those watching live, if you have any questions, share them on the, there's a link to be able to submit questions, and you can do it in the chat on the YouTube page or on Twitter. Just mention @TechGuy and we'll incorporate your questions. But there was a question that just related to what you said, Beth. And the question is, what kind of resources are needed to keep the EMPI clean? So what are the resources you see people leveraging in order to have a nice overlay free zone, or at least as much as possible?
Right. Yeah, if the system you have is not as progressive as the one that Grant has at his organization, I still see customers that go and they check every new registration, they double check. There was one of my customers that did that, and they actually did it from a rev cycle standpoint. So they wanted to make sure that when they registered that patient, that they got the right patient, number one, and then they got the right capture of all the key demographic data. Well, they caught all kinds of things by that process. Their motivation was to prevent denials in claims, but they did that. So absence of the technology tools that some organizations are fortunate to have, there are just manual steps that, it's a lot of work, but the savings on the back end is huge.
I like that you incorporate the revenue cycle. I mean, it's great to have clean data, but that impacts your revenue cycle as well. That's great. So we have another question, unless you had something to add, Grant. But
well, I was going to say one thing we haven't talked about is, load, like when you do a load of data, cleaning that up at the time when you load it in to your main database. That's a pretty big deal. And that's not something that, no matter how many staff that somebody might be blessed with, that's not something they can handle without a vendor's help. So you really need, when you do big data loads, you have an acquisition and you're bringing in 100,000 plus more patients into your master patient index, especially if they're regional. I mean, if it's something, then that happens most of the time. You acquire somebody that's regional, you're going to have, we've seen on some of ours 70+% that we already have those patients in our database. And if you don't go through and clean that up, you're going to cause a lot of problems down the road when the registrar goes to look that patient up and finds 2 or 3 of them in your system. Duplicates beget duplicates. If there's more than one person in there, they get all flustered. They don't know which one to pick. They're going to create a 3rd or a 4th. So I think that's worth mentioning, because there's a lot of that going on in healthcare today. And even in our health information exchange efforts, all these things are going on. And if there's not cleanup when you marry and bring all this data together, that will cause a lot of future problems.
Right. And that is one of the ways that we see technology creating overlays, is that when an organization acquires another facility, they load that data, they have pretty loose matching criteria, and they are loading a record from that external organization that they've just acquired into their database, and they connect it to the wrong patient's record.
Yep, and I mean, all of this goes back to Grant's point that this is only going to get worse, right? As we become more and more connected, it becomes more of a challenge. So there's another question that said, how accurate are out-of-the-box algorithms? So one of my favorite questions in health IT, because everyone wants everything to work perfectly out of the box, but they also want 100% personalization to their system and their implementation. So, what's your take on, how accurate are the out-of-the-box algorithms, and what's your experience with that? Beth, you want to start?
Yeah, we have a lot of experience with this because we've worked with pretty much every algorithm on the market. And so we know, you get XYZ system, you just take whatever the vendor says is the best for an organization, and you deploy it. And typically you're going to either create overlaid records, or you're going to miss a lot of real duplicates in your system. Or you're going to have, or you're going to have a lot of false positives. So a lot of matches that come into your duplicate queue that are not really the same person. So it's something that, because this is what I breathe and eat every single day, I know a lot about. Most HIM professionals are not going to know a lot about this, and I see a lot of organizations that just trust whatever the vendor gives them, which I think is a costly mistake.
Yeah, it's a challenging thing, because they are stretched in so many areas, right? So it's a challenge. How much do you trust, and where do you look for solutions? So, we all want the magic button, but unfortunately, the magic button is called work, right?
Right, exactly. Well, that's the thing. You have to look at the results and test it and see what if it's really working for your organization or not. And quite frankly, that's how you learn how the algorithm works.
That's great. All right. Well, I think we're up against the clock now, but any final thoughts or insights that you could provide as we leave? Maybe Grant, you want to start?
Yeah, I mean, I think I would just say, anybody who is watching this and looking for these tips, I think starting somewhere. You got to start somewhere. Don't, bury your head in the sand and pretend they're not there. I mean, I think there was a period of time when I first started in this profession, 10 plus years ago, we didn't have anything to even know. Like Beth, it was one of Beth's favorite sayings to say, you don't know what you don't know. We didn't know. We didn't have tools to even find stuff. And now there are tools to find stuff. They're not perfect. They don't find everything. They don't, but there is a way to shine a light now into some of this craziness and be like, oh, okay, yeah, we can see some of this. And we don't want to just be naive to that. We need to do something about it. And I think that that's always the thing. I think some of the mentors I've had over the years always taught me that. They said, don't be disabled by, if you can't do the absolute best practice, that's not an excuse for just not doing anything. You still need to dive in and start doing something about it. And I think that's been the best advice, professional and beyond in my life, right? So
that's great.
Yeah.
No, thanks for sharing, Grant. Thanks for sharing all your insights. Beth, you want to wrap us up? And, for those watching live, let them know what Just Associates can do for them. Because, I think that's the other thing is that, like you said, you eat, breathe, and sleep this stuff. So, let them know what are some of the services you can offer them at Just Associates that could help them with this. And how do you work with clients? What's your approach?
Yeah, sure. Our focus is strictly patient identity, so that's all we do. So we obviously do large-scale cleanup projects of duplicates, but we also provide a lot of training and education, consulting services surrounding the identity capture process at an organization and how they can improve it there. We can provide services around how can you best train your staff, how can you do the reporting that you need back to the patient access management team. And certainly we can optimize any algorithm that they are currently using. Because again, that's what we do. We know kind of how they work. We know which systems do what kinds of things and how you can best optimize that particular system.
That's great. Well, I've always been a fan of Just Associates. When I first met you, the thing I liked most about you was, sure, you could do the EMPI cleanup, but you didn't want to just do the EMPI cleanup and then come back and get them as a customer again a year later. Your partner in crime, Jerry Just, he was like, we want to really fix this problem. We want to be their partner, so that we don't have to come in and clean up again. So I think that's admirable of Just Associates to take that stance, because it is a big problem. So thanks everyone for watching live. This recorded version will be available where you can go back and see Grant and Beth's insights. So we'll send that out in an email to each of you. But I want to thank Beth Just, CEO and President of Just Associates, and Grant Landsbach, he's System Manager for Data Governance and Interoperability at SCL Health. If you have any other questions, you want to reach out, you can find me at Tech Guy, and Just Associates is on Twitter as well. So, check them out, interact with us. Let us know if you have any other questions. Reply to the email. We're happy to help you and connect you with the resources you need to deal with this challenging problem. Thanks, Grant and Beth.
Thank you, John.
Thank you.